I think we're just waiting for a couple of more people to join the stream. So we'll begin in a minute's time. Okay. Good evening, everyone, and welcome to Live Life, Live You.
My name is Isha, and this is Dhwani, and we will be the moderators for today's panel discussion. Before we begin, I would like to go over a few ground rules for today's event. There will be no profanity allowed in the chat box. Please refrain from switching on your microphone during the discussion to avoid any kind of disruption. At the end of the event, a feedback form will be distributed over the chat. Only those who complete the feedback form will receive a certificate. Now, without further ado, let's get on to our main event. Firstly, I would like to invite our president, Ansi Wilson, to deliver the opening remarks.
Good evening, everyone. I'm Ansi. I'm a final year student from St. Joseph's College in Bangalore and the president of Consilium. It's my pleasure to extend a cheerful welcome to you all, and thank you so much for joining us today for the panel discussion. I just want to take a minute in speaking about Consilium and what we do as an association in college. So Consilium is an association on campus that strives to promote positive mental health, and we do this by conducting events throughout the year. For this Suicide Prevention Week, we wanted to create a safe space where people can come over and start conversations. We also want to be able to provide a listening ear to those who might be struggling at this point in their lives and let them know that they are not alone and they can reach out for help at any time. And this is how we actually came up with our Survivor September campaign this month. And today being the last day of it, we wanted to end it with our biggest event. And thank you to Dr. Venkatesh and Dr. Preeti for taking time out of your busy schedule to be here with us today. Over to you, Dhwani and Isha.
Thank you, Ansi. For today's panel discussion, we are focusing on the topic suicide prevention and mental health, with the aim to reduce social stigmas and ambiguity surrounding suicide by bringing to attention suicide and positive mental health statistically and sociologically. Along with this, we also intend on encouraging positive dialogue and engagement as a means to prevent suicide. I would like to call upon Ms. Ami Joshi, a professor with the psychology department, to introduce our panelists for the evening.
Hi everyone, this is Professor Ami Joshi from Department of Psychology, St. Joseph's, Bangalore. It's my honor to introduce two experts that we have with us today, Dr. Preeti and Dr. Venkatesh Babu. Dr. Preeti, our first guest speaker, who has MPhil and PhD in clinical psychology from NIMHANS, She's currently a visiting consultant clinical psychologist at Bangalore Baptist Hospital. Dr. Preeti has received training and has had clinical practice in the area of adult mental health, child and adolescent mental health, psychological assessments, individual counseling and psychotherapy, and also in family and couple therapy. Welcome to the event, ma'am. I would also like to introduce and welcome Dr. Venkatesh Babu, MBBS MD Psychiatry, who is a consultant psychiatrist at Fortis Hospital, Bangalore. Dr. Venkatesh is an internationally trained mental health professional working in the field of neuropsychiatry and practices behavioral medicine. He has also underwent training and practices. He has also underwent training and has is certified by International TMS Council. He holds an expertise in non-invasive brain stimulation techniques and electrophysiology for more than a decade. We welcome you, sir. It's an honor to have you here and both of you here, and we're looking forward to know what your inputs are on the topic that we are discussing today. Thank you so much.
Thank you, Ami ma'am. Now we can get started on our session. Ma'am, my first question is for you. Ma'am, what should you do if someone confides in you that they are contemplating suicide?
Okay, thanks, Isha. So I assume that this question would indicate that someone has reached out to you as a person and expressed that they have thought about suicide, maybe that they've planned a suicide act. I think the first thing that all of us need to do is to remember that we need to take something like this seriously, because there's often the risk that we might dismiss it, not take it seriously, brush it aside as a joke, or be uncomfortable with it. So I think the first thing we need to do more mentally than anything else is to be aware that we have to take this seriously. The next thing is to be able to have a caring and genuine conversation with the person who shared this with us. As someone shared earlier, you all have provided a space in your college where people can come, talk, share what's on their mind, hopefully have listeners who are non-judgmental, who are empathetic. And that's exactly what we're talking about here as well, with someone who shared that they've thought about suicide. You would have to be an empathetic listener, someone who's just listening, not putting in your 2 cents worth of opinion, because that's often what we feel like doing, but just listening, giving a listening ear, and showing the person who's sharing with you that you care about them. We know that people who have thought about suicide as an option often come with feelings of hopelessness and isolation, often a sense that no one cares for them, and they feel like they're not connected, or if they die, nobody would actually care. It wouldn't make a difference. So what you're doing when you're listening to them is showing them that you do care, that they are important to you, that there are options other than suicide available to them, right? I think that's really a lot of what someone who's sharing this with you would be wanting. I remember reading about this story of a very old story, I think. As you know, in the US, a very popular place for a lot of suicides is the Golden Gate Bridge. And there was a story about someone who had, told by a psychiatrist actually, of someone who had jumped off the bridge and left a suicide note, which had said, if one person smiles at me, I will not jump, right? And I think it shows just exactly what that person had wanted, just a sense of human connect, maybe someone, not even someone he knew, just a person passing on the road to just stop and smile at him, or, ask him what he was doing and stop him. And I think that's what you would be doing through a conversation where you listen to the person. Often when we talk about what we would say to a person who shares with us about suicide, I think it's also important to remember what we shouldn't say, what's important that we should avoid. We shouldn't dismiss the person or, dismiss their feelings or their thoughts of suicide as stupid or silly or unimportant, because often that's what people would hear, right? They might, you would have to avoid things like saying, oh, it's not so bad. A lot of other people have it worse. right? You'd have to avoid statements like, oh, just get over it, go to sleep, have a good night's sleep, and tomorrow when you wake up, you'll feel better, right? You'd have to avoid statements like, just think positive, right? It's all in your hands, just shake it off and you'll feel better. All of these can come across as extremely judgmental and dismissive. So those are sort of statements that we would want to avoid. And instead say things like, I'm just here to listen. I know this is a hard time for you. I know this is really difficult. I just want to help, right? So you've provided that listening ear for them. And I think after that, it's important to understand how serious or how intentional they are about the thoughts of suicide, or how much of this is a plan in their mind. If you feel that your friend or the person who shared with you is in acute danger, or I think it's your role, maybe your duty, to try and ensure the safety of that person, whether that means making sure that they don't have access to things that they could use to hurt themselves, whether that means asking them and motivating them to reach out to others for help, maybe a mental health professional for help, whether that means bringing in others as well, maybe a supportive family member who can also keep track of them and make sure that they're safe. It would also be important for you to help them connect to the people who could also help, because remember that at the end of the day, you might just be a friend or someone who cares. Maybe they need professional help, and so you can help them connect. Maybe you can help them set up an appointment with a mental health professional. Maybe you can accompany them for that consultation. Maybe you can tell them, once that's done, we're just going to go out and have a cup of coffee together, go out and watch a movie together, right? So that they know you're going to stick with them through this process. And stay with them through that process, connect with them even after that, because it's very often easy to wash our hands off the affair once this is done and say, okay, I've done my bit, it's over. But it's also important to stay connected with the person through this all, even after it's done. So I think those are the main things you'd have to keep track of. Speak to the person, be an empathetic listener, reduce the chances for them to hurt themselves, connect them to the help they need, and then stay connected to them through their help seeking.
Thank you, ma'am. Thank you so much for sharing that. I think we often slip up on using the right statement, so knowing what to say is so important. So since ma'am touched up on the psychological aspect, I was wondering if you could talk to us about the biological factors that could potentially increase the risk for suicide.
Well, first and foremost, thank you for having me here. I think I would like to begin with saying that it is very important to understand the phenomenon of suicide. And the phenomenon of suicide it's an act to terminate the pain, but unfortunately, in due process, the person ends up terminates the life. This has to be understood in essence. It's an act to terminate the psychological pain. I haven't found a single patient who has tried to harm themselves, try to end their life. Eventually, they end up at an emergency. And when I try to evaluate, I think nobody has given me that strong sense that, no, the intent was to only die. I haven't got that even with a single patient. Now, this particular understanding is the core emphasis of suicide prevention, because we are trying to speak about something with a kind of awareness, especially from the cosmos, what we are part of. It is absolutely strongly unaware of what exactly we are going through, and then you just add up mental health, which can't be palpated, which can't be felt, which can't be examined, it has its own inherent difficulty vis-a-vis physical health and mental health. So I think my first and most important tool, what I usually do, not just for suicide prevention, for mental health per se, I say to every patient, every time when I start giving my recommendations, my first line is this, that if there is any best form of treatment for mental health, that is knowledge, awareness. Everything comes afterwards, be it medication, be it psychotherapy, be it a hug, be it a handshake, everything comes later, because if that person has to keep themselves in the strongest position, then they have to be made aware what exactly it is. And moving forward with the biological dispensations towards suicide, see, I think there are so many different biological, psychological theories, sociological theories we speak of, Emily Durkheim, so many different aspects. But I think because you touched upon the biological predisposition, so see, the suicide as a phenomenon is understood neurobiologically, neurochemistry, or genetic perspective, or psychological character traits, or social dispensation. It's a multifactorial model, but when it comes, because my job is to emphasize on the biological entities, the current model of understanding is because the most common form of cause for suicide is mood disorders among the mental illnesses. Mental illnesses per se contributes to almost 75 to 80% of completed suicide. That means there is something beyond mental illnesses can also lead to suicide. Within the mental illnesses, which is the major category, the most common cause being mood disorders, to be precise, depressive disorders. Now, the biological model of understanding is the serotonergic model, which the serotonin is a neurotransmitter in the brain, which is primarily deficient in these individuals with depressive disorders or suicide behaviors. Even within serotonin, we have so many sub-specific understanding that, usually we try to evaluate the CSF serotonin metabolites or platelet serotonin metabolites. Basically, serotonin turnover is being disrupted as a neurotransmitter. So we use a lot of the so-called antidepressants. One such category is selective serotonin reuptake inhibitors. We call it as SSRIs. So basically, we are trying to work on the serotonin neurobiologic mechanism. The other model of biology is your HPA axis, hypothalamo-pituitary adrenal axis, wherein the corticosteroids nervous system and the hormonal system engagement. So this HPA axis regulation is deterred, which is again a backbone explanation for depressive disorders. So these people have a greater sensitivity, higher release of corticosteroids, wherein it is causing a huge amount of disturbance in the stress diathesis model, what we say. Subsequently, we do have so many different genetic mechanisms. There's disturbances in the cytokine, there's disturbances in the platelet mechanisms, leukocytes. These are all part and parcel of engagement explanations, but certain other way of understanding is also such that if you try to understand suicide from a behavioral perspective, impulsivity and aggression is a very important cluster when you connect that genetic predisposition to suicidal implications. Why is it important? A lot of people say, okay, there's a family history of suicide, okay, there's no surprise this person, the heritability component, what we speak. But if you see, there will be a very strong impulsivity and aggressive tendencies which are part of the trait dispensation, which actually is putting them, even without a mental illness, towards the risk of suicide. So all these factors are important to understand, because suicide can be seen as in isolation or it can be seen as part of a clinical disorder. Now we need to have a clearer understanding, because now farmer's suicide is a suicide. A school kid after the exam trying to indulge in a suicidal act is also a suicide. Now, many a times we don't find a clear-cut clinical disturbances prior to that. It is not a diagnosed clinical disorder. So then it has to be understood from a different lens. So I think but none of the factors are very conclusive to report as of now. All the biological factors, none are very conclusive. It is seen in the light of exchanges. Now, compared to patients who try to commit suicide, these neurotransmitter disturbances are relatively different and significant compared to general population, but they themselves are not self-explanatory. That is what I'm trying to say.
Thank you, sir. That I think it brought a lot of things into perspective when you spoke about the differences of the reasons for the suicide that somebody commits. Ma'am, I was wondering if you could talk to us about if whether you could possibly predict suicide in an individual, or like what is something that would tell us maybe this person is calling for help, or how could we in a situation as such predict suicide?
Okay, sure. Okay, yeah. I think that's a great question. I think trying to understand or predict suicide is, I heard someone term it as, the elusive holy grail of suicide prevention research. Trying to understand what factors could predict which person attempts suicide or leads to a completed suicide. I think that's something we're always trying to understand. A simple answer to your question of is it possible would be at the present point, no, right? There is no algorithmic, there's no formula that we use to say, okay, now this is a person who is seriously contemplating suicide and, we have to be more alert to him or her. But I think the truth is that there are various risk factors, like Sir also mentioned. There are various risk factors that could make us alert to the fact that this person may be more vulnerable to thinking about suicide, planning a suicidal attempt, or actually attempting suicide. And there are also warning signs that you and I, all of us, could pick up on, right? That even if a person doesn't tell us or use the word suicide, we could pick up on certain signs. So first of all, with regard to risk factors, I think that's important, right? Like Sir said, one of those risk factors is having a psychiatric illness, but that's not all those who have a psychiatric illness go on to think about suicide or try and attempt suicide. And not all those who attempt suicide have a psychiatric illness, right? And like that, there are various other risk factors that we can be aware of. But it is true that a large number of people who have depression or various other psychiatric illnesses, including other mood disorders, severe anxiety, psychosis, substance abuse, psychoactive substance dependence, could also be vulnerable to suicide. Also, this is a very well-known fact that someone who has attempted suicide before, right, which may not have resulted in a completed suicide, but someone who's attempted suicide before is more susceptible to reattempting again. So just to put it into perspective, for every completed suicide, there are around 20 to 25 attempted suicides, right? And a person who has attempted suicide is very, very likely to reattempt again if not given the proper intervention and help, right? So knowing that someone has, and that also tells us the potential for intervention. If you know someone has attempted suicide, there's a huge potential for how we intervene and prevent this from happening again. So that's another risk factor. Having an individual history of even a medical illness, maybe a chronic medical illness, a debilitating medical illness, something that's disfiguring or that's leaving you really dependent on others for your care, that could leave you vulnerable to, thinking about suicide. Family history, yes, both for genetic reasons and maybe having witnessed suicide in your family. And of course, personality traits. So, if impulsivity, like Sir mentioned, a personality which has high impulsivity, or even people with low coping skills, low problem-solving skills, low ability to regulate their emotions, all may be a little more vulnerable. So what's the point of this? The point is that when you see someone, whether you're just a lay person trying to interact with someone, but you're aware of these risk factors, or you're a mental health professional, talking to this person and trying to understand how much at risk he or she is, you're able to weigh all these factors and understand, is this a person who's at low risk, moderate risk, or high risk, right, to actually attempting suicide. Okay, now that's the risk factors aside. And then we're talking about how could you make out, maybe from your interactions or conversations with this person, that there is a chance of a suicidal attempt. Now, there could be changes in behavior, there could be there could be hints in the way the person is talking, and there could be hints in the person's report of mood, right? So very rarely, I shouldn't say very rarely, but it's not always that the person is going to come and say, I feel like ending my life, right? It might come across through the person saying, I can't go on, nothing matters anymore, there's no point to this all. I feel like ending it, right? What's the point of this life? I feel like I'm such a burden to people, and even if I go, who's going to care? All these should alert you to the fact, right, through the person's conversation, that this is on their mind. You might see, a change in behaviors. For example, a person crying, maybe being aggressive. Another classic sign is withdrawing or isolating from the people who care about him or her. So whether it's you as your friends, withdrawing, isolating, keeping a little more to yourself, talking about death or suicide a little more. And of course, we know that sometimes people who are thinking about suicide tend to set affairs in order. So, have this last conversation with their friends, or, if it's an older person, put a will in place or decide how their children will be cared for, right? Emotionally, I think a very, very high emotion reported is hopelessness. So if you're talking to someone and what you get is hopelessness, what you get is loneliness, the sense of isolation, the sense of nobody cares for me, maybe rejection, I think that should alert you to the possibility that this could be something on the person's mind, and you need to be sensitive to the possibility of this. Yeah.
Absolutely, ma'am. Like you said, there's no set formula that we have to look out for. We just have to be there for our fellow beings and help them, even if it is the little bit of human connect. Thank you, ma'am. Sir, my next question is for you. Sir, why do people attempt suicide when they appear to feel better? Sir, I think you're muted.
Yeah, I think the question is a bit tricky here. But just to clarify that, so do you mean that a person feel better means recovering from an illness, or feel better from their own reporting?
Yes, sir. If just before the event, they will not show any signs of feeling hopeless or yes.
I'll answer both the perspectives.
Yes, sir. Thank you.
See, feel better is at the face value, yes, maybe you try to identify a person in crisis, you try to initiate a conversation, as Dr. Preeti was addressing, how do you evaluate the suicidality of a patient. So you end up, yes, you try to provide an opportunity for the engagement, give them an opportunity for expressing what they have. You try to be non-judgmental, you practice active listening, and then you see that the patient is, for a moment, there's a transitionary change in attitude towards indulging in the act of suicide per se, and maybe that could be seen as you could believe that much deterrence has happened now. The patient may be okay, but nevertheless, that's where the suicidal evaluation lies in place. Now, suicidal evaluation is not just a clinician's forte. That's exactly why we try to do this gatekeeper training with suicide. We try to identify the pre-existing attitudes, the constructs, what they're carrying through. We have to. So when you go into conversation, so one is the crisis management, other is a suicidal evaluation. When you're into the process of crisis management, I think Preeti touched upon, try to smile, try to give a reason, So along with everything, I think most of the points she touched upon, I won't repeat them. Maybe try to end up with a plan. A simple plan, I'll tell you. Every time a patient comes to me, I see that there is a possibility, there's a suicidal ideation. We try to evaluate what are the thoughts. It is important. Number one, you have to differentiate between parasuicide and suicide. Is it the patient really intent towards seeking suicidal behavior, or is it something he's seeking something else? Maybe certain other psychological gain, wherein the patient is trying to push you towards a particular need requirement. And if you try to identify by in the form of inquiring, have they been thinking about this? How often has it been happening? Is there any particular shape of this thought? Is there any particular way or methodology? You try to understand the preparedness of the thought. Maybe have they been acting on the thought? Have they been experimenting or preparing in the form of role play with the thought, or keeping the devices or methodology in access? Now, all these things explain you the intent and the lethality both. Now, these things, when there is no crisis, but when there is an possible crisis, what you are witnessing, then you should end up with a plan. What I would do is this: every time a patient comes in, a patient leaves, I would say, I know it's not something we often do, but I would say that, of all the things, if you think that, you have, at this point of time, if the patient say, no, I'm not thinking anymore, even then I emphasize, next time you get a thought, next time you want to act, I would love to have a conversation with you, even if it has to be online. So what I ask my patient is, drop me a text, not a call. Drop me a text saying that I'm not okay. And you will wait till you get a response from me. Now, that may not be a real-time response because it's an SMS. But it will also give me an adequate time to initiate my contingency plan. And I make the patient coming to us kind of a social contract with this, that I should be the last one if he or she has to talk before the act. So that way, it reiterates a kind of a patient and therapist bond where we are trying to put a strong deterrent program. I call this clinical, in the clinical space, this is my plan, where I try to make my patient come in terms with it, abide by that, and it may not stop or it may stop, but every patient wants to stop what they want to do. Such a kind of thing, it will give them a sense of trust. Okay, this person is ready to listen to me even if everything is off. So, as I said, it is a process of terminating pain. You just have to interfere the process. And that has to be a positive plan. And that's exactly where I feel, whenever you try to engage with someone, you try to engage to an extent that, okay, now let us go and have a cup of coffee, as Preeti said, or I want you to take help, later on I'll catch up with you. Now that's a plan, like, there's a follow-up what you're giving to your friend, right? I want you to take the professional help, or I want you to talk to somebody, I want you to do this, or let us do this. And then there's a follow-up plan. When you place a follow-up plan on a proactive measure, now that follow-up plan becomes part of the psychological expectation for the patient. Oh, I'm answerable here. Now that is what I'm emphasizing. On the face value, you see that, okay, this seems to be fine, but there is a lingering thought because we all go through, what if something goes wrong? So keep a follow-up plan if for a significant one. Now the second part of the question, I also felt the question also has a clinical disorder, let's say depression, and recovering. For example, treatment with an antidepressant. Now, there's a lot of black box warnings happening with antidepressants. It can cause suicidality. Usually what happens is a patient recovering from any form of mental illness, depression, bipolar disorder, PTSD, whatever it may be. Good number of times, we see that patient is recovering and then they committed suicide. Apologies, they died by suicide. Now, what it is they are developing insight into the illness. It is a very, very important entity. The amount of collaterals, what happens with mental illness. I remember very well this patient, She, one of the wonderful, very good, high-achieving IT professional, got into bipolar in the manic phase. This young girl, as young as 24, she did anything to everything, be it in the height of manic phase, the cannabis consumption, she ran around, went away from home, she slapped a family member, she did every possible stuff, and very intelligent kid. Now, the moment we brought her back into illness, the hardest thing which hit was not the illness, the kind of collateral what she went through, the collateral damage. Now, insight or the recovering phase, any sense of anxiety or agitation, these aspects from the clinical spectrum can put a very healthy recovering patient into the zone of suicidality. So both these things are very much pertinent. If you see somebody is doing well, there is more greater caution required at that phase.
Yes, sir, true. And like you said, even if it's a small plan, it can actually make a big difference for them.
Yes.
Thank you, sir. Thank you. Ma'am, next question is for you. How do you think community-based suicide prevention initiatives can be implemented, and what do you think they should look like?
Okay, great. Yeah. So we've, I think, talked about how you can respond as an individual, how you can respond as a mental health professional, but then, of course, there is the community as well and what the community can do. And I think this is important. This is why national suicide prevention policies are important. This is why community efforts are important. I mean, first and foremost, because very often a person who is thinking about suicide may be feeling a lack of community support, right, or a sense of isolation, like I had mentioned earlier. And so, knowing that the community takes something like this seriously or is seriously thinking about this could make a lot of difference. One of the community initiatives could be something like gatekeeper training, like Sir has also touched upon, which is so important. Anyone can be a gatekeeper, right, including, any of y'all. But anyone who has this possibility of being someone who can. So what is gatekeeper training? It would mean you're able to be alert to the warning signs, right? You're aware of the risk factors. You're alert to warning signs that somebody could be thinking or contemplating about suicide or harming themselves. And then you know what to do thereafter. You know who are the people to reach out to. You know how to make sure that the person continues to be okay, right? So the community providing opportunities for gatekeeper training, making sure that the relevant people, right? It could be police personnel, it could be religious leaders, it could be teachers, right? It could be, in fact, just about anyone, right? The community making sure that those who are trained in gatekeeper training, I think, is a major step, right? I think the WHO has also talked about certain things that a community, maybe on a national level, can do in terms of suicide prevention. Now, the first thing would be being aware of suicide rates in the country, right? Being aware of, let's say, people who have attempted suicide, who are vulnerable or at risk, right? So kind of like they call it the surveillance of all of this. Secondly, to be able to restrict the overall access to means of suicide. Right? Now, in our country and in most of the Southeast Asian countries, some of the most used methods of dying by suicide are ingesting pesticides, right, or hanging, or ingesting poisons of any kind. In fact, hanging, and so on. And so there have been efforts to try and restrict people's access to, let's say, toxic materials, pesticides, and poisons, unless they have a reason to use those materials, right? And so methods to restrict access to means, right, is a very important thing that the community can do. Thirdly, the community can influence, plays an important role in terms of interacting with the media, right, in terms of how topics like suicide are covered, right? Whether it's in terms of not just suicide, but also mental illnesses, psychiatric illnesses at large, how these are covered. So the community has a huge role to play in this as well, right? Whether it's in terms of generating guidelines for how the news media covers something like this. Fourthly, identifying those who are at risk and making sure that active support is given to those people at risk. Right? So that's another huge effort that the community also has to play. So I think all these put together form a very comprehensive plan, from gatekeeper training to very individualistically looking at people who need the help, and then working through the news media, restricting access to means. Yeah.
Thank you, ma'am. Like you very rightly said, the first step is with the community, and unless we do that, it'd be very, very difficult to prevent something like suicide or death by suicide. So my next question was to you. what else can we do as individuals to prevent suicide besides talking to the said individual or urging him or her to seek counseling? I mean, what are the other methods in which we can help them?
Well, I think again, largely the question is about so at the individual level we have discussed. I think Priti has already addressed about at the community level what we need to do, but as a caregiver or as a citizen of a society, okay, so there are other aspects. I think I would begin with the same aspect. Building knowledge and awareness is the most important key. Now, the question would come: what kind of knowledge awareness building what we can do, and what are the challenges we find in this? I have been very much interested in the new digital age and human behavior, and if there is one thing which has changed the attitude in the last 18 months, it is human vulnerability, and there is no exit to it. That's called pandemic. Now, it bent us for two things. One, it made my mom use YouTube. At the same time, it made my brother talk to me if when he is having work from home difficulty. So both the things were difficult otherwise to do. What I mean to say is, sometimes when we are put into an experimental design, we imbibe those skills, we teach ourselves. So knowledge awareness requires a huge amount of research and innovation, and there has to be a lot of work happening. Yes, there's a lot of work happening on the social media giants, how to track people, youngsters, especially targeting youngsters who are prone for any form of suicidality or mental illness. Facebook has been running its own algorithms. So is the Twitter and Insta. Like now, they are trying to make algorithms to identify human behaviors, who is posting. Almost 90% of the times, people in one way or the other they communicate verbally, non-verbally, in person, or through digital presence. You even now, every time we see a celebrity death due to suicide, we see that now a lot of everybody goes back into their profile and they'll see what's the last post been placed upon. But if you see, there would be certain messages, be in the form of poems or the songs which has been dedicated, or a post which is as though remotely not about them, but it is about a neutral topic. Everywhere, if you see, there are the string of pearls which has been left. So what is essential is knowledge awareness to tackle the stigma and the shackles of discrimination. But I think my first conversation with every patient, I think I try to I've been using books for the last 10-15 years to work in the field of mental. Now I'm trying to use my own patients to understand it. And my very strong understanding is, when I think Priti will agree, when you institutes like Nimans and CIP, we don't have the luxury of sitting with patients to make them understand and teach them what is the best way of going ahead with it. Make the patient, yes, to a certain extent we do that, but there's a huge amount of workload. But what is essential is you have to invest time, and you have to make the family understand. And the moment you make the first break with the family that this is something which is essential, because it takes a huge amount of time to instill into people. So all kinds of activities are required for knowledge building. Every one of us has to speak. My standard punchline is this, that I tell to all the family members, I don't believe the world at large understands mental health or mental illness. I don't expect anybody to understand. I don't expect my mom to understand. My primary belief comes from a patient who is suffering from mental illness, or a family who has a person with mental illness, are the only ones who know the true suffering of mental health. They are very easily ready to take the knowledge what you are imparting. Rest of them, it's a choice. So whenever it is a choice, it needs a new way of branding and engaging. I believe, a lot of places the conversations happens about romanticizing mental health. Maybe rebranding mental health is essential for the conversations has to happen around mental health. Okay. Otherwise, the parents end up in the situation where they have an adolescent kid now, they don't know what to do. This involves even doctors. That's when they say, okay, how should I deal with it? Either I push my child to the wall or I go into denial. I say there's nothing, it exists. So if there is one thing which can change, that is an attitude of openness for all possibilities. So try to be open to experiences. Now, this is not only for mental health, this is for ourselves per se. Okay, so the openness, the attitudinal change, which shall lead to knowledge exchange, shall lead to healthy practices. I think these are the stepping stones when it has to go on a societal level. And every time the patient comes, I try to make sure that I talk 45 minutes where I give all the possible emphasis, which I can't do sitting in a premier institute. And next consultation onwards, if I'm not part of therapy sessions, I only need 5 or 10 minutes at the most. Because by that time, the patient and myself have a wonderful trust established. We know what we are speaking about. So my theory is educate the patient and ask them to make learned decisions. So your approach has to be, as a caregiver, keep on working on a continuous models. There's no immediate cutoff where, okay, I win or I lose. It's a process. It has to be process-driven models where constant, just like our CMAs, continuous medical education, it has to be continuous educating models where we have to impart knowledge, because attitude change only when it is in a continuous learning phenomenon.
Absolutely, sir. Like you said, it is going to take a long time, but we will not give up, especially in this fight, because knowledge imparting process is, like you said, for the family who's experiencing it, they might take it faster than their society. But as caregivers and helpers who would like to help in the least way possible, we can do our best. Thank you, sir. My next question is to both of you, ma'am and sir. Based on your personal experience, can you tell us why individuals are so afraid to talk about mental health issues, illnesses like depression, bipolar disorder, and suicide? Why are such important topics always hushed? Like, would you like to discuss how, even if it's the smallest way, how to destigmatize these topics?
So, sir, would you like me to go first? Would you like to share?
Yeah, I can take it actually.
Sure.
Let me ask you this question. I think so. You may be a student of psychology or otherwise, but I can ask you this question: what is the most private thing in human existence?
Our thoughts.
Ah, that's such a bang-on answer. There is nothing which is private than your thoughts and your emotions. Maybe vice versa, mutually each influencing each other. There can be anything else which can be private. Your physical appearance may be private, may not be private. Okay, your your act, your engagements, whatever happening in the real world cannot be private. I'm a private person being in marriage. I don't say stuff to my wife which I think, but I don't say. Even being a legally wedded husband, I don't say stuff. They are my own private thoughts. I don't say stuff about a patient, even if I think something or not, even if I like or not, it's private. I don't say stuff to my own parents. So even if it is as close, as significant, as private a relationship, even within that, there is something called as private. That is thoughts. Something which we don't stand in front of a mirror and tell to ourselves. That's what I mean. So now just come back and ask, how comfortable is it to sit in front of a chair and talk to me and say that this is what I'm going through? I didn't share it with my partner. I think the most closest companion in this world. I didn't share with my parents. I didn't share in front of myself. And then I had to sit and talk and share it to a stranger completely unknown to me. I think it requires an enormous amount of courage. I don't think you, me, all of us, unless we don't get into that distress, we will be ready to do that. And I think the courage comes from the distress. That's what I believe. A person in such a great amount of emotional pain beaten, bruised, and exhausted, then they say, no, enough. I can't take it anymore. I want to understand it. That's where a person, maybe by himself or by the family support system, says, yes, now I want to talk. I think it requires a huge amount of courage, and that's where the real challenge comes in. We say, on platforms like this, yes, we have to create awareness, do this, that. No, actually create awareness to keep the societal attitude towards in a particular standing. That is to take away the discrimination, but that does not solve the problem. A huge amount of emphasis should be given to say that it is okay not to be okay, and it is necessary that mental health is as important as physical health, and it requires a huge amount of courage to walk in and take help. And in fact, I'll go a step further. Irrespective of the diagnosis, bipolar, schizophrenia, mood disorder, PTSD, OCD, I think generational understanding is also making a huge amount of difference. So many of you guys would be into centennials, maybe 90s and afterwards. So if you see, I think every parent says that our childhood was very different. You guys are very sensitive, very touchy, very blessed. You guys have wonderful stuff. If we rewind 100 years back, a father would sit down and say the same stuff to his own son. I think it has not changed. Why is it? It doesn't change because there are certain generational differences because what if one generation persisted and lived for 200 years? What if one generation lived for 200 years? No, there are certain things, actually this also comes from understanding the psyche of generational development, how the personality of self has evolved. Which generation people has evolved to what way. Now, if you see, youngsters like you guys are very quick to make a conversation about mental health compared to your parents. You're quick to converse. But at the same time, your parents believe that they don't have mental illness. That's why they don't talk. But you guys talk because you have issues at every possible level because you have a very extreme low tolerance. I think previously for some conversation, some kind of panel discussion or platform, I have been searching, is there any definitive literature supporting this? So I stumbled across a wonderful article which said, what are the coping differences between generations? And one such wonderful coping mechanism difference, the comparison is between the, let's say, centennials or millennials and anybody prior to that. There are healthy and the unhealthy coping mechanisms we're all aware of. There are different ways. One of the most important coping mechanism the current crop, the centennials or millennials use is distraction. And the biggest distraction is your mobile phone. Just put your head into the sand and then you're done. The entire problem disappears. But one of the healthiest way of coping is problem solving. Attending the problem, finding a restructuring of the thought. What exactly is okay? Why my thought process is not fitting in? What am I missing it out? What is hurting me? Or seeking information. So information seeking is done by centennials. Everybody Googles. Dr. Google is the most qualified expert. But the extrapolation of Google, it's so quick to distract again. You put yourself into the social media quicksand and you take yourself away from the problem. So all these things are, in a way, contributing towards a change in attitude towards seeking help, but at the same time, it is deterring a person to make an open conversation. We are heading towards dual identities, virtual and the real self. They are dual identities. And I think there's going to be more and more conversations around this. But what is essential is the answer is the same. What's your grandma has taught you? You have to sit back and spend time and talk. Parenting is a full-time responsibility. That's what I feel nowadays. Not you have to sit and talk to your children. Not you don't consider that as an option. You should consider that as a choice to be made. You have to spend those 1 to 2 hours, which should be away from the phones. Now these things are become norm of the day because it was easy. My dad was working, my mom was not working. Somebody was always addressing me. Now, with both the parents working around, there's hardly anybody addressing except the mobile phones. So all these things, you know what? Suicide is a societal phenomenon. It is very multidimensional. You don't just address suicide by talking to a person. No, it has to have on so many levels. And I think if there is one domain what everybody can access, that is called as family, and that's where the enormous amount of work can happen if the family support system exists. Because again, one more risk factor: unmarried, poor social support system pushes a person into the space of suicidality far more than any other social attributes are. Social support system is a make and break. So you need not be in the same geographical space, but you have to be emotionally connected, tied upon, be constantly checking in. I think these are the things, you know, actually what is so because it's so private and then it is so difficult to make the conversation with the attitude. So I think that's where the multiplanar approach which we have to take.
Just to add on to what Sir was saying, why is it so difficult for anyone to have a conversation about mental illness and then suicide? I think first and foremost, it's the level of stigma and discrimination that there is about this entire topic. It's not easy to talk about it. We're mental health professionals, we're students in psychology, and so it's a lot easier to use these words. But otherwise, they're such taboo words, right? And they are taboo words for the people who are experiencing it. So, for someone who is going through depression, or for someone who's feeling low and who's actually thinking about ending their life, it's also associated with so much of shame and guilt, right? It feels like it's the fact that I could be experiencing this is so shameful. And if I tell anybody about it, what are they going to think about me? What are they going to think about my family, right? It's like a black mark against my name and my family's name. And this can be, the opposite of what they need. This can kind of shut them into a box and isolate the person more instead of allowing them to come out and speak to others, which is what they need to do. So unfortunately, I think that's the sad truth. These are topics that are not talked about, although the fact is that these are topics that should be talked about the most. And this is going to affect how much a person is able to seek help. Right. So, health-seeking behavior is going to be seriously affected if a person feels that this is private and this is wrong and this is something I shouldn't be experiencing. And if anyone knows, what is the world going to think about me? There is also, the general, let's say the public's ability to talk about something like this, let's say even suicide. There's this huge myth, I'm sure you all know of this, right? This huge myth that if we talk about it, we are going to plant the idea in someone's mind, right? Or if we mention the word suicide, then, people who never thought about it are going to start thinking about it. And then, God forbid, someone's going to actually actively plan or die by suicide, right? But I think that's a misconception that we all need to address. It's like saying, if I think I have diabetes, I will have diabetes, right? It's as great a misconception as that is. So I think the opposite is true. We need to be able to have conversations about mental health, about topics like suicide. We need to be able to have open conversations. And I think, programs that start from very young ages that, normalize the aspect of mental health issues, taking help for mental health, play a huge role in this. So, yeah, thank you.
Thank you for sharing, Sir and Ma'am both. We're almost nearing the end of today's panel discussion. Participants, if you have any questions, feel free to type them in the chat box, along with the name of the panelist to whom you are directing the question. We'll start with a couple of questions that we've already received. So would you have time for that? Or?
Yeah, go ahead.
Lovely. The first question that we got was, what is the difference between self-harm, suicide, suicidal tendencies, suicidal thoughts? If you could just touch base on what these are, that would be...
I think in a different context, we have already discussed about this. So basically, this is part of societal assessment, what we need to understand. Whenever you try to evaluate the phenomenon of suicidality in a patient, you try to understand, is it at the idea level itself? Is that a patient has been what we call it as a wishful thinking? A patient says, "Oh, I don't want to live. It's better that I die." Now that is just a wishful thinking. It's a it's a emotion based, triggered based thinking. It's a fantasy driven thinking just to get rid of the pain. Now that does not involve any definitive plan, any proper action forum or anything. Now, if you try to see somebody just indulging in a conversation about terminating life or wishing that would have been easy an option, now there you have to try to see that. Now, if the person is trying to play out this behavior to a particular end point, in order to achieve a certain other objective, maybe as a form of temper tantrum, or maybe as a form of an engagement with the family support system to communicate a certain behavior, then it has to be demarcated. It may be a parasuicidal behavior. Now that is a plain cry for help behavior that does not involve anything beyond that. Now, if there is a clinical population which is involving if there is a wishful thinking which is amounting to a frequent ruminating thought, a thought which is about the probabilities of ways of trying to harm self or end life and means of doing it. So then the frequency, the intensity with which the person is indulging, the underlying mood state behind that, and the extent to which the person is acting on the thought. Now, I think Preeti touched upon this. Consuming anything. Maybe in India, pesticides is the most common, one of the common ones. Consuming is the most common way of trying to harm oneself. But if you go to Western populations, firearm is the most common one. Now, why is it different? Because it is understood by the concept of accessibility and availability. What is easily accessible and available for a young man or a rural man is definitely something to consume. Firearm, licensed or unlicensed, is difficult to access, but that's not the case in West, let's say USA, where every person has three rifles or pistols accessible in US. So try to evaluate whether there is a proper shape of the thought in the form of how they have any plan towards it, and then move a bit. Next step is, if so they have thought about it, how did they come to this? Why did they choose this as a medium? Some don't want to have the pain, some don't want to communicate it to. There would be an explanation or reasoning behind that, whatever the methodology they choose. And then have they tried to put that plan into action? Okay, so many a times, if somebody wants to hang themselves, they try to get the substance, they try to hide it somewhere. Maybe they do that even months prior sometimes. But usually people prepare for that. Now, all these things, every step, if you start ticking off yes to every possible thing, that in a way converting into the lethality and the intent towards suicidal behavior. Now, that is what determines it. So whenever, I think I would agree with that. Now, talking to the patient is not going to encourage the patient to commit it. Be very clear about that. Talking may make the exact job opposite. Maybe it may end up being a deterrent, or it may end up an opportunity for the patient to ventilate that, they don't want to do that. Now, giving an opportunity and making the patient say that is very, very essential. Because many a times, the thoughts happening in the mental space is happening in the mental space. It's like reading a book and teaching a book, It's very important when you make a patient say, "Oh, I don't want to live, I want to die. I think this is what I'm planning to." When you say that, even your auditory processing is telling your brain what you're thinking, There's a new sensory input to the brain. That is also works as a deterrent. When I say out loud anything, I'm also understanding what am I thinking. But when I'm only thinking here and acting out, I don't give it's called proofreading. You don't proofread your thoughts here. Even if you do that as part of your metacognition, when you say out things, before you do, you're proofreading it. Okay? So when you hear what you're saying, that may also be a self-deterrent. It is very essential if you go through. And that's exactly when we do a clinical bedside suicidal evaluation, I think these are the aspects. Other than if there is associated impulsivity, I believe it has one important entity as far as suicide assessment is concerned, which has to be kept in mind.
Thank you so much, sir. I think there's one last question since we're running low on time. Isha, do you want to take this?
Ma'am, this question is for you. Ma'am, what are the consequences of the glorification of suicide in media?
Okay. I think a hugely relevant question.
Yes.
Hugely relevant, yeah. I think we are live witnesses to the fact that the way media displays or talks about such topics can have a huge influence on how people think about things like suicide. Right? This is not something new. Even in the days before our widespread mass media, when it was still just printed media like books or newspapers, the way topics like suicide were covered still had an effect on actual behavior in society, right? I'm sure if you've read about this, you must be knowing about something called the Werther effect. I don't know if any of you have heard of this, right? Which was back a few centuries ago when a book talked about the suicide of a character. There were a string of copycat suicides that followed using the same method, right? And that was a few centuries ago, and now we have the same thing happening even now. We know that if there is a glorification of a suicide in the media, which is basically talking about it excessively, talking in detail about the means in which the person died by suicide, talking excessively about the events that could have led the person to think about this, talking excessively about what's happening after that, right? More so than in any other news story, that's glorifying it, or that may be even called sensationalizing it, right? I don't know if that's the right word to use here, but that is in a way making the story a lot bigger. And we often see what is called a string of copycat suicides thereafter, right? This could be through the role of news coverage of a celebrity suicide, right? This could be through TV shows or movies which depict suicides in great detail. And I don't need to name shows or name movies for you all to know what I'm talking about. Even in the last 3 years, there has been evidence of this, right? If you look back. So I think governments all over the world are saying that the news media has to be extremely sensitive in the way it covers such topics, right? More with the aim of helping people and more with the way of generating awareness than covering the story per se. So guidelines include the fact how you talk about suicide, the terms you use, right? The fact that the means that the person used are not emphasized, right? Rather that maybe helplines that a person could reach out to if they are thinking about suicide are available in the same news story, right? Or different things like that. If you're going through anything of the sort, reach out for help. I know this because even yesterday and today, as I was preparing for this, if I just happen to type in the word suicide prevention, the first thing you'll see on Google is a nice big helpline number saying, if you're thinking about this, reach out to this number, right? And that's the same thing that happens in all our news stories, and that's responsible reporting. So while the glorification, like you use the term, the glorification of suicide can be detrimental, I think the reverse is also true, that more than any single individual or any national policy is the role of the media, and that the media can play a huge beneficial role as well in educating people about mental health and in maybe generating positive responses. So I think research has also shown this, that if the news media talks instead about stories of how a person might have been experiencing thoughts or suicidal ideations, but then overcame that, sought help, and felt better, it has a huge positive response. I mean, it has a huge beneficial effect as well. So that could be a huge positive role that the media can play. And then just our previous question, we talked about stigma and, why people don't talk about it. So just normalizing this talk about mental health and the importance of mental health is something that but is something that the news media can play a huge role in. So I think it goes both ways. I think it's a hugely relevant question. Thank you.
Thank you so much, ma'am and sir. I think with that, we come to the end of today's panel discussion. Apologies to the participants. We're running a little short on time, but I'm sure that all of us have had an insightful session with, of course, our distinguished panelists. I would now like to call upon our Joint Secretary for Documentation, Nana Mary Sebastian, to deliver the vote of thanks.
Hi, good evening, everybody. Thank you so much for joining us today for this discussion. Before we wind up, I'd like to take a little bit of time to extend our gratitude to a few people. Firstly, I'd like to thank our eminent panelists, Dr. Venkatesh and Dr. Preeti. Thank you so much for taking time out and having this discussion with us. Having these conversations about suicide and suicide prevention is something that we all believe is incredibly important. And this webinar has helped us develop a deeper understanding about the issue, and has also helped us learn so much about what we can look for, how we can actually be helpful both as individuals and as a community, and that, sometimes it's okay not to be okay. I'd also like to thank our college, St. Joseph's College, especially the School of Humanities and the Department of Psychology and Counseling for giving us the opportunity to conduct this event. A big thank you to Consilium and the organizers of this event who made this possible and ensured that everything runs smoothly. Last but definitely not the least, I'd like to thank our audience for being here today. Our campaigns and our efforts to raise awareness would never work without your support, and we are ever grateful for this. Once again, I wish you all a good evening. Thank you so much.
Thank you, Nana. Now for the attention of the participants, we have provided the feedback form in the chat box. Kindly do fill them out before you leave so that you can receive your certificates. Thank you so much, everyone.
Thank you for inviting us to be panelists. We enjoy the experience to be able to talk to you all, interact with you all, and share our thoughts. So thank you.
Of course, ma'am. It's been a pleasure. Thank you so much.
Thank you very much for inviting. I think I'll just leave with a last closing remark because there's such an intense conversation happened. I do make this conversation with a lot of young ones. We all have to do our role, but I believe the greatest balancer of all is technology, not human beings. Mahatma Gandhi or Martin Luther King or Swami Vivekananda did not get women out of their homes to be what you guys are right now, working, independent, functional women. I believe the greatest change is not because of man's attitude or human's attitudinal change, but it is the technological advancements as simple as, let's say, sanitary pads. Now that put you out of home, that put you in a space where you drive, you define, you decide. So if I call women as disadvantaged a century ago, today I call mentally ill or mentally health issues, people with mental health issues are disadvantaged. And they believe it is the same technological advancements which are going to give us the greatest leveler of it. Man versus man is always going to discriminate, be it man or woman. But technology doesn't discriminate between man and a woman, ill or healthy, physical or mental health. So mobile phone revolution is going to bring in, and that's where I see, yes, it's going to fragment us, but it is also give us an opportunity to see better numbers as far as suicide are concerned and the positive numbers as far as people with mental health are concerned. I think, thank you very much for this wonderful engagement. I think more work should happen from you guys. You are the voice, and feel free to talk to us, and I'll just close it up with We do have a Fortis helpline, which we do cater 24/7 in 16 different languages across the country, manned by psychiatrists or clinical psychologists, all possible point of time. So please do share possible resources wherever, whenever we need. Let's try to help each other. Good luck, guys. Thank you.
Thank you so much.
Thank
Have
you,
a
sir.
lovely evening.
All the best. Bye bye.
Yeah.
Thank you.